I will start our recording formally. And while I'm waiting for additional people to come in, I do have a few housekeeping announcements for the group. I am still waiting on a number of folks to complete the research and partnerships spreadsheet. So if you have not yet done so, please do that by the end of the week. It's very important that I have that information so that I can ensure I'm telling an appropriate story about the different research themes or partnerships that each individual is pursuing. If you have questions about that, about what is required to input, or really a larger question around what your partnership or research should entail, those conversations need to be scheduled sooner rather than later because we are almost at the halfway point in the semester. So if you require additional support, know that that is what I am here for and eager to help you with. So I cannot anticipate that on your behalf though. So I do need you to identify that and reach out to me so that we can get some time scheduled and get those conversations started. Related to that, I was looking at the mapping data spreadsheets that are also in the shared drive, and I have not seen hardly any lines highlighted. And I know I had indicated last Friday as a deadline for that, but recognizing that does not seem to be an appropriate deadline, I wanted to ask the group here how much additional time is going to be required before that can be completed. I do acknowledge some folks are doing that as their research assignment this term, so that won't be finalized until end of April. But for those who are just reviewing and updating, how much additional time approximately do you anticipate needing before that can be finished?
I just have 2 things to go review, so I can get those done, and I'll get those done in the next 2 days, but I've pretty much reviewed everything and all the information. I'm also in a city where Philadelphia, of course, somebody already did it. So I just have 2 more categories.
Okay, great. So if I were to say by the end of next week, okay. Okay. I've seen enough head nods to make me feel confident in saying end of next week for that information. If you have questions about information that you thought would be reflected there, would like additional information on what is expected, how to do that upload, again, reach out to me. But again, I cannot anticipate what your questions might be. I think I've provided as much information as I would anticipate. However, again, if I can provide any clarification, point you towards additional resources, know that is what I am here for. Great. Well, I am very excited about our speaker today. This evening, we are joined first and perhaps foremost by some additional sunshine here in DC. So I'm delighted that it is still bright at 5:04 p.m. Eastern time. It's always a welcome shift in the season. And just as sunny, we are joined this evening by Tiffany Russell from SAMHSA, which is the Substance Abuse and Mental Health Services Administration. Tiffany is the Chief of Crisis and Justice Initiatives with SAMHSA's 988 and Behavioral Health Crisis Coordination Office, where she serves as an advisor to the 988 director and other members of SAMHSA's senior leadership in planning and determining policy, programs, and activities that address complex challenges in coordination of 988 crisis centers with law enforcement, 911 call centers, and emergency medical service providers. She also develops, recommends, and implements programs and provisions of guidance related to improving crisis response for individuals with behavioral health needs that minimize unnecessary law enforcement involvement and promotes diversion from the justice system. Before joining SAMHSA, Tiffany directed the Mental Health and Justice Project, which focused on improving behavioral health crisis responses in state and local governments for Pew Charitable Trusts. Before joining Pew, Russell served as the Director of Strategic Planning and Research Development in the District Court Administration for the Superior Court of Fulton County, Georgia, where she was responsible for building the court's capacity by developing policies, programs, and processes to enhance the administration of justice and increase access to justice for all. She's also held several positions in grant management, research, strategic planning, public relations, and communications in nonprofit, government, and education organizations. Tiffany, thank you again for being with us this evening. I hand the floor to you.
Thank you so much. I appreciate that. This is a pleasure to be here and be able to speak to you all about the work that I do every day, and hopefully answer any questions that you might have around 988 and the Lifeline, as well as crisis services more broadly in its intersection with the criminal justice system. I know that we just went through my bio, but just to give you a little bit more background onto how I got into this position and how I got into this field. I will first of all start off by saying that I am not a behavioral health specialist. I'm not a clinician, a psychologist, a social worker. I am also not a law enforcement officer. So I've never been a police officer or anything like that. But what did start me on this journey was the death of Trayvon Martin. And at that particular time, I wanted to figure out what I could do to help my community to get through that situation and to avoid it happening again, especially as we think about the interactions that Black and Brown people have with law enforcement and the justice system. How could I improve that space? And so I did what a lot of you all did. I stopped my Master's of Public Administration degree about 2 semesters in and studied for the LSAT and got into law school. I was going to be an attorney, but I was not excited about litigating. I wasn't excited about standing in front of a judge and pleading a case. I really just wanted to have a much better understanding of the law and how it works. And so I did not go. And let me tell you what happened there. So in the process of, I was accepted into John Marshall Law School in Atlanta, Georgia. And I was going to do their part-time law program. I was going to continue to work full-time. At that particular time, I was working in the school system as a community liaison. And so I was still intending to work full-time and go to law school. I don't know what I was thinking, but that was the plan. But in going through that process, my brother-in-law and I both did this process at the same time. He also got into law school. And he informed me that I should reach out to judges to start working on getting an internship that would allow me to work full time, and how could we manage my schedule in doing that. And we knew it was going to be a lengthy process to find someone who could accommodate me. And so in the process of doing that, I found the position that I secured with the Superior Court of Fulton County in the District Court Administration. I was talking to all of the judges at the Superior Court about being an intern and how I could work as a part-time student. And they were looking at my resume and finding out my skill set. And they said, we actually have a job open here at the court that you probably would really be good for. You probably should look into it. And if you're in the courthouse, it might be a lot easier for us to do this internship with you. And so I applied for the position. I actually got the job, and it was the Director of Strategic Planning and Research Development. This was the first job of its kind in the court. And at that particular time, when I got the job, I was one of 3 in the country. There was one in DC, and there was one, I think, in Texas. And I was the 3rd that had a full-time position of that sort. And basically, I was the strategic planner for the court. I looked at all of the initiatives that the judges wanted to undertake, what was going to be best for district court, especially thinking about case management. And as we were having that conversation, the pain point for the judges was specifically around their caseloads dealing with individuals that had mental health conditions or diagnoses. At that particular time, I wasn't that familiar with it. I was okay in that subject matter, as I worked in a behavioral health crisis center, but I was again working in PR, I was working in grant making. I wasn't really on the clinical side and understanding how diagnoses worked and all of that great stuff, all of the services. And so really it was a crash course of learning for me about how mental health and the justice system intersected, how they interacted. Why was it taking so long to get these cases through? Why the dockets were the way that they were, and how could we change that in working with not only the judges, but prosecutors, the district attorney's office, the public defenders, as well as the jail. And in doing that, we developed a subset of priorities specifically for our strategic plan. And I created the City of Atlanta, Fulton County Mental Health and Justice Task Force, because I knew I was not going to be able to do this work alone. And so I brought together all of the stakeholders to the table that needed to be there. That included law enforcement, the justice system and all of its players, as well as behavioral health providers, and county and city government, because of course they hold the funds. And so if we want to establish something, we have to have someone that can pay for it. And so over the course of about 2 years, with about 275 task force members, we developed 25 recommendations for how to deal with individuals that were coming into our justice system. Some of the big priorities or some of the big wins that I think we have there, one was that we were able to shut down the City of Atlanta jail as it related to individuals coming into the jail with mental health diagnoses, because it was the majority of the folks that were coming in on misdemeanor charges. We were able to divert them into other programs and essentially shut down that wing of the jail. We also put a pitch in to change that wing of the jail into a diversion center, where law enforcement or first responders could drop off individuals that were experiencing a behavioral health crisis. And instead of taking them to the jail for intake, they could take them there for services. And they're therefore avoiding being processed through the criminal justice system. Some of our other big initiatives were that we were able to divert a lot of the folks that were coming into our county jail as well into other diversion programs. We implemented a behavioral health, mental health screening where we could identify folks early on so that they could be put into special pretrial programs that were related to mental health. And we also were able to significantly decrease the number of the length of stay for folks that were coming into to the jail with mental health diagnoses, because of their awareness and because we were able to get them into other programming, therefore kind of ending their cycle through the criminal justice system. So through all of that work, I got to be pretty much a speaker. I joke and say that I went on a tour of going through different states and counties and cities to talk about this particular initiative. And I got the eye of Pew Charitable Trust, who invited me to come and move to DC to take on their behavioral health and mental health and justice project work. So I moved to DC in the very beginnings of the pandemic in May of 2020 and started that work there where we really focused in on behavioral health crisis, because that was where the initial focus was and where we saw that was where the most impact could be made. We really started looking into how things happened with 911 and when people call into 911 and how they're receiving care through 911, what types of responses they're receiving. Is it police? Is it a mobile crisis team? Is it a co-responder team? And I'll talk about those kinds of interventions a little bit later, but we were really interested in how 911 impacted their journey into the criminal justice system and how we could divert them there as well. Again, because of the work that I was doing for Pew Charitable Trust, I got the eye of SAMHSA, and they invited me to join the 98 team, which is where I am right now. So I'm happy to get started. If there aren't any questions about my background, I'm happy to get started in talking about 988 and crisis services. Okay. Let's see here. And is everyone able to see my screen? Okay.
We can, yes, thank you.
Great, great. So for today's presentation, just wanting to go through and give you an overview of the need for 988 and what that is. Talk a little bit about SAMHSA's priorities, as well as the 988 and crisis service vision, get more into the details about 988 and its lifeline. And then we'll journey into some of the criminal justice initiatives that I have in my particular portfolio, and then get into some questions for the group. So the need for 988. So for those of you who are not familiar with what 988 is, the National Suicide Prevention Hotline was started in 2005. It was a network of call centers that you could call specifically related to if you were thinking of committing suicide or attempting suicide. It was a way for you to speak with a trained counselor that could talk you through your current crisis and your situation, and also connect you to any types of services that were available in your particular area, and how to gain access to those crisis services. There was about 3 years prior to 2021, a campaign that instead of having this long 1-800 number that most people could not remember or were not familiar with, that we should change that to a 3-digit number, very similar to 911. That would be easy for everyone to remember. It wasn't complicated, and it almost reminded you of 911, but it's specifically related to behavioral health, mental health, and crisis services. And so what we did was started this campaign. We pitched for legislation to be changed, to make this public number of 988 statute. And that was passed in late 2020, that the 988 number could get started. At that particular time, we had nearly 900,000 youth aged 12 to 17, and about 1.7 million adults that were attempting suicide at that particular time. And that was one of the reasons why we needed this new number to reach more folks, to get more access to care and services. We had approximately 1 death by suicide every 11 minutes. And for a lot of people, which was one of the major reasons why we really wanted to get this number changed, was that for people ages 10 to 14 and 25 to 34, suicide was the second leading cause of death for these particular age groups. We also include in this number and the services available through this number, drug and substance use issues as well. And at that particular time, we had about 105,000 folks that were dying from drug overdose. So the reason why this was so important for SAMHSA to take on as an initiative is that it fell right within our priorities and our principles. And so the 5 priorities that we have here at SAMHSA is enhancing access to suicide prevention and crisis care, promoting resilience and emotional health for children, youth, and families, integrating behavioral health and physical health care together, strengthening our behavioral health workforce, as well as preventing overdose. As well as these being our priorities, the principles that we lead by is to ensure that all of these services are equitable, that they are trauma-informed, and that there is a commitment to data and evidence, and most importantly, recovery. So the vision for 988 and the crisis services, you'll often hear us say the crisis care continuum. And so for SAMHSA, the crisis care continuum includes that there is someone for you to talk to, there is someone to respond to you, and that there is a safe place for you to get help. And so the lifeline is an important step towards achieving that vision and having someone to talk to. The lifeline is available 24 hours a day, 7 days a week. And that the crisis care system is a robust system that provides crisis care needed anywhere in the country. So as I mentioned earlier, the 988 Suicide and Crisis Lifeline, which is its official name, which was formerly known as the National Suicide Prevention Lifeline, it helps thousands of people overcome crisis situations every day. And from the numbers in our data, it shows that the access to a crisis counselor actually works. That after speaking with a trained crisis counselor, many of our callers are significantly more likely to feel less depressed, less suicidal, less overwhelmed, and more hopeful. So when we're talking about someone to respond in a safe place for help, this is our transformed crisis care system with 988 at its core. And this can't be built overnight. And so a lot of these services are available for the majority of the country, but the majority of the country is not our goal. We want it to be available to everyone, and that includes rural and urban populations, Black and Brown people. It includes tribal nations and communities. And we do that by connecting people to community-based services such as mobile crisis care, which are mobile crisis teams. They can include a licensed counselor or social worker that comes out and comes directly to the person in need wherever they are located to provide them with care on the spot. And then also serve as a case manager that can assist them with connecting them to the services that they need in the community on a more consistent basis. It also includes stabilization centers. And what we mean by stabilization centers is this is the place where you can go to actually receive services, whether that's inpatient or outpatient. And again, this is part of that consistent care that you need, but you have to get stabilized first. A lot of our stabilization centers also have detox services so that if someone comes in with a substance use issue, they do have the ability to detox so that they can then deal with their mental health conditions from there. It also includes our community-based providers. And so those are our psychologists, social workers, case managers, therapists. It also provides tools and resources that you can have access to on your own and have the ability to learn more about what kind of crisis services or services are available in your area. You can find out what types of services are available to you based on your insurance carrier. There's a variety of different types of resources that you can do that are self-guided. And it also, again, just comes back to community-based behavioral health crisis services. And so again, when we think about crisis, we don't try to identify or determine the definition of crisis for folks. We let folks kind of tell us what crisis means to them. And so crisis can mean you're having suicidal ideation, meaning you've thought about suicide, you've started making a plan for that. Or it could be as simple as you've had a very stressful day, you feel overwhelmed, you just want someone to talk to. You don't feel quite like yourself, and it's affecting your work, your life, your job, your family, your interactions with friends. And that can be a crisis as well. It just depends on that particular individual, what a crisis means to them. And so we want to make sure that we have a variety of services that can be available to that individual for their needs specifically. For the office that I work in, it was created under the legislation that established 988 as the new number for the Suicide and Crisis Lifeline. And we have two major roles in this particular office. Our first role is to serve as the lead federal organization of the 988 Suicide and Crisis Lifeline, and as well as serve as the lead federal agency for behavioral health crisis services in its transformation. So as the lead or federal organization for the 988 Suicide and Crisis Lifeline, what does that mean? Well, we manage the cooperative agreement with the 988 Lifeline Network Administrator. And so our office does not specifically directly manage the 275 plus 988 centers across the country. That work is done, the network administrator is a Vibrant Emotional Health based in New York. So they are responsible for working directly with those crisis centers. They're independently operated in a variety of different states. They're in there's at least one in every state. They are also responsible for the technology that is used by those crisis centers, as well as the policies and procedures. And so basically they are the administrator of that, of the lifeline. And then we manage Vibrant Health and making sure that they are meeting the criteria for what we deem as success. We manage their metrics, their data, and ensure that they are responsive to not only the centers, but to also the federal government as well, and making sure that they are using the funds that we provide for them to be able to bring this service to bear. We also provide the funding that helps to administer states and territories and tribes strengthen their 988 services. And so we provide grants to each state that has a 988 network center available, and make sure that the grant funding is there to make sure that they have enough staff to provide, because prior to 988 being an official number, the majority of the centers that provided the services to the National Suicide Prevention Lifeline were basically volunteers. And so if you can think about having to rely upon volunteers to operate a 24/7 center, that can be quite difficult. And so through making 988 an official number, we were then able to offer these positions as paid positions so that we can make sure that we had the capacity to handle the volume of calls that come in to the centers daily. It's also our responsibility to align and coordinate 988 communication with external partners and the network administrator, and we're also responsible for leading those campaigns. And so what you'll start to see over the course of the next couple of months, if you have not heard about 988, you will start seeing banners, you'll start seeing TV commercials, you'll start seeing ads in various places to share with you that 988 is now operating and live. We wanted to wait a couple of months to ensure that we could meet capacity as it stood. And also to make sure that we were able to work through any kinks or any challenges that we were able to identify in the first 6 to 7 months of operation. And so now that we've been able to work through that, you'll start to see the national campaigns come out. Very similar to if you think about the tobacco campaign that was going on for several years, it'll be very similar to that. You'll start seeing it as commercials during your nightly shows and things like that. We'll also start with sharing it in schools, in elementary schools, all the way up to colleges to make sure that we're also getting that message across to various age groups. And serving as the lead federal organization for the crisis services transformation, again, we have done a fairly good job of ensuring that mobile crisis services and crisis stabilization centers have the appropriate funding to be available to most individuals across the country. We know that we are not anywhere near where it should be in order to provide access to those marginalized and underserved populations, rural populations, as well as tribal communities. And so we need to scale those services and ensure that they are readily available and that they're meeting the needs of the populations that we hope they serve. And so as part of that transformation, our office is responsible for articulating the long-term vision of what we want for crisis services. We coordinate federal action, not only within SAMHSA, but across the Health and Human Services Department, as well as with other federal partners like Department of Justice, Homeland Security, and other federal agencies such as that. We drive strategic partnerships with our states, our territories, tribes, and other external partners. We disseminate data and quality standards for all crisis services, as well as monitor, evaluate, and then communicate the effectiveness of all of our services as well. So those are the main priorities of our office. So how does the 988 Lifeline work? So as I mentioned, the service is available 24 hours a day, 7 days a week. When you call into the crisis line, when you dial 988, you are connected to a trained crisis counselor. And what I mean by a trained crisis counselor, I don't necessarily mean that it's a psychologist or that it's a therapist or that it is a social worker. This is someone that has been trained to handle crisis. They are trained in de-escalation. They are trained in effective communication for when someone is in crisis. And they are also trained in understanding how to connect a person to the crisis services that are available in their area. So when thinking about this, when you call into the number, you are not required to share with us your name, your location. You don't have to give us any of that identifying information. You can simply get on the phone and talk and just share whatever it is that's bothering you that particular day. I know that a lot of folks have had a lot of concern around whether or not we are able to automatically know where you are when you call in, like when you call into 911. Our crisis line does not have geolocation services available. So that is not the case. That is a myth, if you've heard that. 911 can do that, but that is not the case for 988. And so if we want to know where you're located for whatever reason, you will have to share that information with us. And so when you call into the lifeline, before you start speaking with that trained counselor, there are 3 prompts available. So the first prompt is, if you are a veteran, you can be connected to a special veterans crisis line where they are specifically trained in how to deal with veterans and also are very familiar with veteran services. If you press 2, you are connected to our Spanish subnetwork, meaning you'll have access to someone who speaks Spanish fluently, and they can provide you with the same care and provide you with services also available in Spanish. For those who speak languages outside of Spanish, you still have the opportunity to be connected to someone that speaks your language. We do have access to a language line that has more than 200 languages available. But we do have one where we have specific Spanish subnetworks where those calls go directly to a crisis center that only speaks Spanish. And then the third prompt is to the LGBTQI+ support for people under the age of 25. And so we are working with Trevor Project, and they have developed a line that is specifically for that particular community and how to handle their services and how to handle dealing with that particular population. And so, as I mentioned before, you are you're connected to a local crisis center. And when we say you're located to a local crisis center, what they're using is the area code for the number that you're calling from. And so an example of that, I have, because I am from Georgia, I still have my Georgia cell phone number. I am currently located here in Maryland. So if I were to call from my house here in Maryland to the 988 number, it is going to connect me to the crisis center in Georgia because it is based on my area code. So again, we do not have the ability to automatically connect you with a crisis center that is in your particular area unless you share that information with us. So if I were to call 988 and I was connected to the Georgia Center, I could tell them if I choose to that I am not located in Georgia, that I am in Maryland, and I would like to be connected to a Maryland crisis center, and they can transfer me over. If you don't want to do that, you don't have to, but that is a choice because, again, if after the conversation you want to learn more about what types of services are available to you, it's better to go ahead and get connected to a crisis center that's in your particular area so that they can look at what's available to you directly. With this implementation of 988, something that we have not had before is the ability to chat or text. So that is a new system that we have with this service. So prior to this, the only option you had was to call and talk to someone. With a new change to 988, you now have the ability, you can text 988 and speak to a counselor that way. But you can also go online and chat online as well with 988, a 988 counselor. So just to talk more about some of the federal funding that we received to do this big push in this initiative, as you can see, as early as fiscal year 2007, the funding for the National Suicide Prevention Lifeline was around $2.9 million. As we started to build the case for why we needed to build this system, why we needed to scale our services, we started to see very small incremental increases to the funding for the National Suicide Prevention Hotline. And as I stated before, still with it's receiving increases, the majority of the staff that were working in these national crisis centers were still volunteer. And so when we thought about what we needed to do in order to ensure that we could meet the capacity for this now being a national number that is available to everyone, that can text and chat, and that could basically be an alternative to 911, we knew that we were going to have to pay these trained counselors in order to make sure that we had the capacity available to meet the need. And so through the Biden administration, we started to receive the funding based on the legislation that was passed. And as you can see, there was a major jump from fiscal year 2021 when the legislation passed to when it was implemented. So we went from 23 million to 432 million. And just as a note, over the course of the Biden administration, they have invested almost $1 billion into the 988 system over the last couple of years. So the number was put into action or implemented on July 17th of 2022. That was when it officially turned on, where you have the ability to not only call 988, but then also chat and text 988. And so some of the metrics that we've seen from that date in July to December of 2022, we've received more than 2.1 million contacts from July to December. If you compare that to the same 6-month time frame in 2021, we've answered more than 892,000 contacts and significantly improved how quickly those calls and contacts were being answered by the line itself. Our calls increased by 43% because chat and text was brand new. Chats increased by 224%. And texts increased by over 1,000%. And now it stands that our average speed to answer those calls went from 2 minutes and 46 seconds to approximately 49 seconds. And so if you want to get more information specifically about 988, and this is again some of where I was talking about wanting to know more about not only the 988 services, but about crisis services more broadly in your particular area. Here is just a list of all of the websites and resources that we have available. We have a page specifically for 988 on our site, on the SAMHSA site, where you can get more information about 988 in general, where you have access to our partner toolkit. We have our performance metrics where you can see by month, every month, how well the crisis line is doing. And eventually we will get to a point where you can see how well the line is doing in your state. We don't have that right now. So all of the numbers we provide are an aggregate of all of the calls across the country. We also have access to, if you are interested in serving as a trained crisis counselor and to begin getting trained and be a part of the lifeline itself. We also have access to jobs that are currently available across the country in various systems and centers. And then it also provides with funding notices about any types of federal grants that we have available related to improving 988 in your particular area. So just to talk a little bit more about my particular portfolio, the first line of work or work stream in my particular portfolio has to do with 988 and first responders. As I mentioned before, in my work with Pew Charitable Trust, there was a really big issue around 911 and how the emergency system responded to individuals that were receiving behavioral health crisis calls. And so in the research that I did, we found that not a lot of 911 911 call centers not only do they not have training, they also do not have a specialized protocol to receive those calls. So they handle them the same way that someone calls in to report a burglary or a heart attack. And you would think that if this was someone identifying that they're having a behavioral health crisis, that they would have a specialized training or protocol for how to respond to those calls or triage those calls. But many of the 911 call centers do not have that. A lot of the 911 call centers are also not aware of what crisis services are available. And so if someone were to call 911 and say, I'm having suicidal ideation, or I think I want to commit suicide, they don't have the access to send anyone other than police. So there's not an ability for them to send a crisis center or a crisis call team, a mobile crisis team. If they are aware of a co-responder team, which is a police officer and a trained social worker or a trained therapist, sometimes they have access to that and they have protocol where they can transfer the call over to them. But most of the time, the protocol prohibits them from transferring that call due to liability and risk on the local government. And so a lot of them, they don't have the ability to transfer those calls over. They also don't track their data around behavioral health calls. And so it's really impossible to know at any particular given 911 call center how many of these types of calls they receive on a monthly basis or an annual basis. More importantly, one of the major issues that I have with 911 is that there is not a place or a national repository where we can get 911 data at all. So if you think about it, there is no one singular place where it exists that you can go and look up how many 911 calls are made in America annually. It does not exist. 911 call centers are mainly managed by local law enforcement agencies. So it could be the state police, it could be the city police, it could be the sheriff's office. It just depends. It's going to be a variety across counties. It's going to be a variety across cities and states. And if you've seen one 911 call center, you have seen exactly one 911 call center. They all do things very differently. Even if they're in the same local area, they can still do things very differently. And so when we were thinking about how to interact with these 911 call centers as 988 was coming on board, we thought this would be a great resource for them to have. If someone who was calling into 911 expressed that they were having a behavioral health crisis, where we could transfer these calls over to 988 and they could have more appropriate health first, health focused care. But it takes a lot of work to get there. We have to develop protocols. We have to develop call triage decision trees that are implemented into their CAD systems, which is the system that 911 callers use when taking these calls. And there's also a lot of concern around liability and risk as well. And so having to work around that and developing looking at the local laws and statutes as it relates to that particular area. And so one of the things that I'm responsible for is ensuring that we have a coordinated 988 and 911 emergency response system. And we're trying to do that through 3 ways. The first is policy, the second is practice, and then the third is publicity and promotion. And so in the policy, it's around the decision-making, advancing the decision-making around legal issues involving first responders and the 988 network. And so as I mentioned before, because statute is different for every single 911 call center as it relates to how they manage calls, we have to develop as the federal government a standardized process or protocol that can be established for them to connect those 2 services together. So we're looking at all of the policy impacts that happen around that particular area and where we have say so as the federal government when you're dealing with such a localized system. And then under practice, we're identifying best practices around 911 and 988 collaboration as well as developing all of the alternative responses to law enforcement when someone is in a crisis. And so there are several communities and states that are already working towards 911 and 988 collaboration. California is a great example. In LA, they have the D.D. Hirsch system, where the D.D. Hirsch behavioral health provider works with all of the 911 call centers within LA County. And they have established decision trees and protocol for how someone who is calling into the 911 call center specifically for a behavioral health concern. And because of that, we're looking into the way that they establish stakeholder collaboration. What were those protocols? How did they avoid the statutes? How did they work around the statutes? What were the changes that needed to be made in order to make this collaboration happen? There's also a service here in Maryland, in New York, Utah, Arizona. And so there are certain states that are already taking the lead in moving towards this collaboration. And so we're working with them to identify the best practices that they have pulled out and learned about this early 911, 988 collaboration. And then how can we share this across the country so that everyone can participate in making sure that these services are coordinated. And then finally, that last piece of publicity and promotion, it's really about educating not only the first responders and the criminal justice community, but also EMS, that includes firefighters and ambulance services and other groups about 988, with the goals of collaboration, the integration of 988 into their toolbox of services, and as well as identifying resources and trainings that they will need to help them perform their work with a health first tilt. More broadly, there are a lot of other things outside of 988, 911 that I work on as it relates to the intersection of criminal justice initiatives. And so some of our major themes in the work that we're doing really rely on equity and access, the engagement of law enforcement, first responders, and the justice community, our education and policy development, the promotion of best and promising practices, community engagement, and funding and sustainability. And so when we think about equity and access, and so we know that in a lot of communities, especially Black and Brown communities, they have a very, there is a hesitancy, not only about 988, but a hesitancy in using 911, because they feel as though they won't receive the help that they need. They will just be received by law enforcement, which means they're either going to end up in jail or receive a charge. And so a lot of the communities will not use these types of services, regardless of if they are in crisis. Most of them will sometimes use the emergency rooms. They'll use community services that have no affiliation with law enforcement whatsoever. They'll use family members. They're also really not that keen on using traditional crisis services or mental health services as well. A large part of the reason for that is because a lot of our mental health and behavioral health workforce does not look like them. If you look at the American Association of Psychiatrists, only 2% of the psychiatrists in our country are of color. And so if you're thinking about the person that you want to work with you on your issues dealing with depression or anxiety, and they don't truly understand your community and your community relations, your faith, your cultural indicators, it's going to be really hard for them to be able to provide you with care. And so when we're thinking about all of these particular initiatives and developments that we're making, we're always being very concerned with making sure that equity and access is at the center of that. And when we're talking about communities of color as well, we're also talking about tribal nations, and a lot of tribal nations in our country don't have access to some of the basic services that we kind of take for granted. So a lot of tribal nations don't actually have access to 911. Within their particular communities, they have their own special services, and that if they actually need access to broader health care, they have to sometimes travel up to 2 hours before they can gain access to those services. And so imagine being in an ambulance if you're having a heart attack and you have to travel by ambulance for 2 hours just to be transported and switched over to a different ambulance to actually get to like a general hospital or a community hospital in that particular area. That's what a lot of tribal communities have to deal with. They have their own tribal police and tribal police associations. And so they think they handle situations and very differently. And so we have to think about that when we're making these adjustments to 988 in order to collaborate with them. When we're thinking about the engagement of law enforcement, first responders, and the justice community, I mean, advocates in the mental health community will tell you that a lot of them have the feeling that they do not want there to be any contact between law enforcement, first responders, and the justice community whatsoever when it comes to mental health care. And we understand that, especially those that are connected to communities of color. The issue with that is that if we were to disconnect first responders and the justice community completely from our crisis services, that there is going to be a lack of resources available. There are so many populations that even at our best effort of trying to ensure that services, mental health services are available to everyone, there are still just underserved and under-resourced communities all across the country, and either in rural and urban populations. When I was working with Pew, there is a particular police district in Dallas, Texas, which we think of as a large city, that did not have access to any behavioral health crisis services other than police. And so we started in that particular area of Dallas that covered an entire police district and implemented co-responder teams with not only a police officer that was specifically trained in how to deal with mental health and behavioral health crisis. That team also included a paramedic, as well as a trained counselor that could go out for these calls when they were received into the 911 system. This was the first time that they ever had access to any of these types of services in their community. And so when you think about, when I say that there are communities that don't have access to these services, I don't necessarily mean very small, rural communities out in the middle of Idaho or North Dakota. Like, I'm talking about large urban areas that also do not have access to these crisis services as well. And so when you want to disengage law enforcement and first responders before we have the implemented services in those areas, you're essentially leaving them with nothing. They have no resources whatsoever. In our other major activities that we're working on as it relates to our criminal justice initiatives, we're identifying, innovating, and building off-ramps to care. And what I mean by off-ramps is that most people think about when we're looking at the crisis continuum, is someone to call, someone to respond, and a safe place to go, meaning that the last or the end point of that is at the connection of going to a crisis stabilization center. But what happens if a police officer actually responds to that 911 call and they come out and for whatever reason, they decide to either take that person to jail or they take that person to the emergency room? And most oftentimes we don't consider what happens after that point. We essentially think, well, they're now involved in the justice system, so we don't have access to them. That's not necessarily true. There are still a lot of opportunities to off-ramp that person back into care, back into community-based services, and being able to avoid and deflect them from the criminal justice system. And so part of my portfolio is making sure that we build out what those opportunities are, that we fund them appropriately, that we scale them up in major areas, especially where it's concerning those minority populations, because they are the ones that have the higher numbers in jail, and they're more at risk once they go into the criminal justice system as well. And so we want to create and identify and innovate what those off-ramps can look like, even if it's outside of the established crisis care continuum. It's also important that we developed a shared language. And so in the time that I've been working in this area, one of the things that I always notice and I emphasize is that when you're in a room of law enforcement, criminal justice, or the justice community, and you're talking about behavioral health, especially if you are a behavioral health provider, a therapist, a counselor, a social worker, you use very different language from them. And so it's oftentimes you're comparing apples to oranges. You're not saying the same thing. Crisis to a behavioral health community and crisis to police are two very different things, and they are not the same. And so one of the things that we need to establish in order for this collaboration to work at this particular intersection is making sure that we have a shared language, and making sure that when I say crisis, it means the same for you, and it means the same for a police officer. It means the same for a prosecutor. It means the same for a behavioral health provider. We also want to develop best practice academies. And what that means is that it's really easy for us to put these wonderful papers together, issue briefs, and come up with guidelines that tell states and local communities how they should implement these services in their communities. But if you don't do this work every single day, if you're not involved in it, reading a 345-page brief on the national guidelines for creating a efficient and effective crisis system mean nothing to you. And so best practice academies are where we bring a group of stakeholders in a particular area. It can be for a state, it can be for a local community. And it's really just a 3-day crash course in how to implement these types of strategies in your area. And we make sure that you have all of the necessary players at the table. So as you're all learning, you're learning together. And so then you have this built-in kind of buy-in that you can take back to your community and implement these types of services. And so you're surrounded by subject matter experts that are there to share with you and break it down to where you can understand what we're sharing with you, how you can implement that, the challenges and barriers that you're going to encounter, and really give you the tools and the resources that you need to be successful in your particular community. And so we want to make sure that we're not only developing those best practice academies that are needed, but making sure that we're funding them appropriately and making sure that we have enough of them to really make sure that this is a successful strategy for them. We're also going to be issuing out white papers and case law reviews and briefings on challenges. And so I've talked quite a bit about liability as it concerns 988 and 911. And so whenever I have this conversation with a law enforcement association, a law enforcement agency, when I talk to local city managers and county executives about transferring calls between 988 and 911, the first thing I hear about is like, well, who's going to be responsible if something tragic happens? Where does the liability fall? And so if the call comes into 911 and we transfer over to 988 and that person dies and their family sues, who's responsible? And as much as we try to talk through the policies and procedures that are currently in place, we know that that is a big concern for them because they're risk adverse. And so one of the things that will help with that implementation of coordination and collaboration is that we do need to do a case law review of liability as it relates to the statutes in every state. And I think that's what's going to make them feel more comfortable with having the conversation around collaboration, makes them feel a little bit safer in implementing these changes. Is because we've issued a white paper, or we've done a case law review, and a lot of the issues that we deal with are going to have these types of challenges. There's a lot of policy at stake. There are going to be statutes that need to be reviewed. Again, statute changes state by state. And there might be legislation that has to be passed by the government as well to help implement some of these changes as well. And so those are some of the challenges that we'll be identifying and also drafting documents to help with. We'll also be convening focus and work groups on implementing these policy changes. We'll be cultivating states, jurisdictions, and tribal communities to work at the local level. And then we'll also be here to provide research and technical assistance to those states, jurisdictions, as we work through all of these challenges with them. And providing them with the assistance that they need, whether that be with a consultant or subject matter experts that work with them hand in hand as they kind of work through all of these different challenges and creating a more efficient and effective crisis care continuum system. So I want to stop here. That's the end of my presentation. I do have a couple of questions that's open for the group. But before we get to my questions, I don't know if there was anyone that had questions about the presentation itself, about the services that I was describing as far as 988 and crisis care services that I can answer before we get to these questions.
Tiffany, thank you so much for that. What a fascinating overview. I think this has definitely answered a lot of the questions that I had about 988. There's been a few lingering ones since it has been launched. So just for my own edification, I appreciate it. I am going to take moderator's privilege and pose one additional one that has been in the back of my mind for some time. If and when you see someone experiencing a mental health crisis, are you able to call 988 on behalf of another person, or is it only in response to an individual issue?
So a lot of the callers that call into 988 are calling on behalf of someone. And we do have family members that call on behalf of an individual to 988. And the best thing that they can do is then give them the resources that can connect them to services within that particular area. So for example, if you were to see someone out in your community that you think is experiencing a crisis call, you have two options. If you are familiar with your 911 non-emergency number, you can contact the non-emergency number, or you can call 988 and 988 can give you the information for the non-emergency number, or they can also give you the number for a mobile crisis team that could come out and help that particular individual. So there are still resources available through using 988 where you can help a person who is not necessarily someone you know or a family member. It could just be a random person on the street, and they can still provide you with access to services that are available to help that particular individual without having to call 911, which may lead to the police coming out.
Got it. That's super helpful. Thank you. Laxmi, see your hand raised.
Thank you for this interesting presentation. I wanted to know, you said when you're talking about SAMHSA and 988 dispatch, I was wondering if you could talk about what criteria SAMHSA uses to train the 988 dispatch to identify individuals in mental health crisis and then determine when law enforcement or the CID is involved.
So when it comes to 988 dispatch, as far as the training that the counselors receive, it's quite a rigorous training, actually. There's a lot of focus on their de-escalation and their de-escalation techniques, identifying triggers for that particular individual. There's also a significant amount of training on equity and access. And so each crisis center is trained on how to respond to the minority population within their area. So for example, in Washington State, the counselors there are trained to be able to respond if the person identifies as being part of a tribal nation. So there's a very specific line of training and services and language that they use in working with that particular population independently. Washington also took it a step further, and they have now initiated a tribal nation line where other members of tribal nations can respond and answer those calls as well and be trained to provide them with the types of service and be able to use the language and culturally be able to understand how to work with that particular individual. I don't want to give the indication at all that a trained counselor is a therapist or a psychologist or anything like that. Some of them are, a lot of them are. They do this as a volunteer work, or they do this just because they find it important. They are attached to this particular work. And so there is a certain, so while we can't give you all of the training that a psychologist or a therapist may have, we do give you enough training to answer those types of crisis calls. And it's almost a 3-month process that they have to go through before they are actually put on calls. When it comes to 911, that's one of the things that we're trying to implement is a training for 911 call takers and responders in helping them to identify individuals that are experiencing a crisis call. One of the major things to know about this is that oftentimes when someone calls in to a 911 call center, almost similar to the example that Jesselyn mentioned, when they call in, sometimes they don't say that person is having a behavioral health crisis. Sometimes it's called in as trespassing. It's called in as panhandling. It's called in as disturbing the peace. It's called in as public indecency, or, maybe they're using the restroom on the corner of the street or something like that. So it comes into a variety of different ways. And we've identified about 7 or 8 call types that are typically associated with this person being in a behavioral health crisis. There are actually people who have called in that are actually, they may call in and say, a person is experiencing a diabetic situation, either going into shock. And surprisingly enough, when your blood sugar drops too low, it mimics the same symptoms and outcomes of someone experiencing behavioral health crisis. I don't know if anyone knows that or not, but like if your blood sugar drops too low, you have slurred speech, you hallucinate, you hear things that are not there, and I know this firsthand because my grandmother suffered from it. And so, when her blood sugar would drop too low, she almost used a baby voice, and that was how we knew something was happening. But if someone didn't know that about her, they may call in and just say she's having a behavioral health crisis, or they might call in and say she's having a diabetic issue, and they don't know that they're experiencing, because the symptoms they're so much similar. So what we do is we want to develop the training for call takers at 911 call centers to try to identify, so pull out the information from the caller to get more information and more insight on the situation that's happening, and be readily available to state that this is probably a behavioral health call. Oftentimes what happens is 911 will dispatch law enforcement. Law enforcement will get on scene and decide that it's a behavioral health crisis. It's actually not trespassing. It's someone having a psychotic break. It's not trespassing. It's actually someone who is having an anxiety attack in front of their house or something like that. And so you oftentimes, the call comes in as something different. And the purpose of wanting to get the data around that is because then we can start to evaluate if we're correct in the call types that we've identified, but also so that we can reconcile that data with the police reports that come in from the police on site. Because the difference is that the call comes into 911 and it might go out as panhandling or trespassing. The officer on scene will then submit their report and say it's a behavioral health crisis, and they're not reconciled because the two systems don't talk to each other. So this is the importance of why we need the training and the data, so that we can start to identify those circumstances better, so that we can properly train them for how to identify these calls as they're coming in. But then also when they come in, help them to be able to de-escalate the caller on the phone and get them to a place where they can transfer the call over to 988 or a mobile crisis team or some other type of service.
I was wondering more in terms of data points, if there's any short-term or long-term studies of the effects of 988 on diversion or pattern usage. So you were talking about behavioral health crisis centers being used more versus individuals in mental health crisis being sent to jails. And I was wondering if you have any data about that and what data points you used to make that determination.
At this time, we don't, simply because 988 got started in July of 2022. And so we don't have, I think, the enough of the relevant data to be able to make those types of assumptions just yet. But I think as part of the responsibility of our office is to determine the data metrics that are needed to evaluate the effectiveness of whether or not this is being used as diversion for these other individuals away from the justice system. And how can we do that if they don't, one, provide us with identifying information, such as their name or location or their phone number or address. And so we will have to use other types of services or other types of services data. So we'll have to use like EMS data as well. We want to develop 911 data so that we can identify places there. But for now, the data that comes into us, if the person gives us consent and use it, provides us with that information, our 988 centers can tell us a certain level of information, but it won't give us a complete vision of whether or not we diverted or deflected that individual from going to jail.
Thank you.
Holly Harrison, I see you've got a question in the chat here. And also, if others have questions in the chat, just because there's been a fair bit of back and forth there, if you just raise your virtual hand, I can put you into the queue. But Holly, I'll throw it to you.
Okay, thank you. I was curious about if a local police department has a crisis intervention team who responds to mental health crises. Does it make sense, like if I or someone I know is having a mental health crisis, to call 988, or should the person just reach out to their local crisis intervention team?
So I think that depends on your comfort, your level of comfort. If you are familiar with that team, meaning you've had interaction with them before, your family member has had interaction with that team before, I would definitely encourage you to reach out to that center or that team to establish contact there. But if you're not familiar, if you haven't used them before, I would suggest calling 988 first and being connected to a team that is not associated with law enforcement. Simply because if you have not experienced this before and you're not sure what will happen, in the case of police responding, sometimes what we've seen is when police show up on the scene, that person automatically shuts down and they either become super aggressive, they're not open to getting help or being assisted. And that's typically what ends up causing them to catch a charge for assaulting a police officer, which leads them being taken to jail, unless they are familiar with them. And a lot of the centers or the teams that are in particular areas will go out into the community to make sure that they know everyone in their particular area. You'll see them at community fairs and health fairs. They want to be introduced. They want to make contact with the folks that they have, that they know are needing services or assistance. So they'll go to the group homes, they'll go to the crisis stabilization centers and start making contact with them there so they feel more familiar. And so that if they are in a crisis, it doesn't come off as aggressively, if they are just a shock and it's a stranger that is approaching them. But I also know that in a lot of areas, there aren't a lot of options. And so if the only option you have is a co-responder team that includes a police officer and a mental health clinician or a mental health professional, and you don't have anything else, then I would definitely opt to go for that team versus calling 911 and just having police come out. Because even if that team is available, again, some 911 call centers don't know that these teams exist. And so they'll just dispatch police and not have that co-responder team go out. And that's the one thing that you want to avoid in that particular situation, is you don't want them to just have contact with law enforcement. So it's really about the level of comfort. If you are familiar with this team, this mobile crisis team, and you think that they will respond better, I would contact them directly. If you're not familiar, if you don't have there's been no initial contact before, I would start with 988 and hopefully they can find a mobile crisis team that does not involve law enforcement at all to make first contact and move forward that way.
Laxmi, I see your hand again.
I was wondering, if a mobile crisis team or a co-responder team responds, does SAMHSA have any best practices guidelines or any protocol developed that indicates who's in charge? And also, are there any data statistics showing how often the mental health professional part of that team is remote versus in person?
So we do have national guidelines for mobile crisis care and mobile crisis teams, and it's available on our site. It's also used as part of any grant funding that we offer to those teams for operations, that they have to follow those guidelines. There is some give and take though, as it relates to who makes the first contact. Most oftentimes it's done by the mental health professional. And the officer is simply there to secure the scene and make sure that things are safe, the safety of the mental health professional as well as the individual experiencing the crisis. But again, that can also change based on your local jurisdiction and your county and your state, as to how the operation of the team, how they make first contact. But typically what happens is the mental health professional makes first contact because it is established as a health first approach. And I didn't quite catch the second part of your question about data as it relates to.
The data as it relates to the adherence of these best practices guidelines or these protocols developed by SAMHSA, how adherence is defined and how that's measured in terms of how closely the guidelines are followed by different co-responder units or mobile crisis response units.
So the only data that we receive from our mobile crisis teams is through the ones that we fund specifically. So if we provide them with a grant fund, we provide them with grant funding. They provide us with monthly reports about the effectiveness of their services. And so the effectiveness of their services not only judged by what happens day of or at the time of the incident, but it is also about follow-up. If the person was connected to community-based services, meaning are they connected to a therapist or a psychologist, medication, housing, jobs. There's a whole other group of requirements and other things that they are required to do. It's more than just going to that point of responding to the initial emergency. There's also a criteria about follow-up and other aftercare that they are responsible for. And so we receive that data from them if they receive grant funding. Now, if they are not receiving grant funding from us, we do not have access to their data as it relates to that. And there are a lot of mobile teams, crisis teams that do not receive funding from SAMHSA because they do not want to work with law enforcement whatsoever. And so if they don't want to work with law enforcement whatsoever, they don't receive, they don't want to be connected to our funding. And our funding doesn't require that they work with law enforcement. We ask for collaboration. We ask that they make a connection with their law enforcement agency just to make sure that they are aware, so that the law enforcement can use them as a resource. So we don't put in our guidelines that if a mobile crisis team is funded by SAMHSA funds, that they have to have a law enforcement person that responds with that team. That's not the case. But a lot of community-based mobile crisis teams don't want to have anything to do with our funding because they don't want to have that collaboration with police at all.
What is the primary source of the data you collect? Is it mostly police reports, or do you also get data from the mental health professionals?
For the mobile crisis teams?
Yes.
For the mobile crisis teams, they provide that data to us directly. So a lot of our mobile crisis teams are based in behavioral health care centers that also receive SAMHSA funding. And so we receive that data directly from the behavioral health center that they are associated with.
What about the law enforcement arm of the mobile crisis response unit? Do they also provide data?
So if law enforcement is the primary provider of the mobile crisis team, typically they're not receiving SAMHSA funding. They're receiving funding from DOJ, the Department of Justice. The Department of Justice, under the Bureau of Justice Assistance, has what they call law enforcement behavioral health sites. And so they provide them with funding because the law enforcement hand or arm is the primary provider of the service. So while we don't get their reports directly to us, we do work in collaboration with DOJ and that particular grant funding series. And so we share the data back and forth. And so we get the data from them, but they don't report it to us directly.
Okay, thank you so much.
Yeah.
Katie.
Thank you. That last bit is actually really interesting. So for within the DOJ, for the Bureau of Justice Assistance, they're providing funding. Who can you just restate? They're providing fund. It sounds like law enforcement first through the DOJ and then health first through SAMHSA. Is that like?
Yes. So for the yes, you're right. So the services or the teams that are mainly based out of behavioral health centers, meaning they're based out of your local behavioral health center. It doesn't have to be a crisis center. It's just your behavioral health center that provides mental health and substance use services to anyone in your community. They don't have to be in crisis. That could just be where you go for your therapy services, where you go for your medication, anything that's related to mental health or behavioral health. If that mobile team is based out of your behavioral health services, more than likely, 99% of the time, your funding is coming from SAMHSA through Medicaid, Medicare, or SAMHSA grant funds. If you have a mobile team or a co-responder team that is the primary provider is law enforcement, meaning the sheriff or the city police decided, we get a lot of behavioral health calls that come into our center. We want to train our police, and we also want to employ mental health clinicians that go out with our police officers to respond to these calls. Their team typically receives their funding from the DOJ because they're a law enforcement entity. We are not a law enforcement entity. So the Department of Justice has a series of funding that's just related for law enforcement who wants to implement these types of services and grants through grants.
That is really fascinating. Sorry, my kid is sick, and so there's TV. There's been TV in the back room, in the other room for 3 days now. My question was about so just thinking about, I was thinking about the thing that you said about police reports, how there's this like discretionary capacity when law enforcement is responding to determine that something is a behavioral health situation rather than a criminal situation, even though it's still in a police report and still in the criminal, like it's still on the criminal track, right? And so in that framework, right, where one of the ways that kind of like coding something as a behavioral health problem comes in is in the context of criminal defense, right? Like, so you don't have, maybe someone didn't have the mental state to be disorderly, or everyone has the mental state to be disorderly, but like maybe someone didn't have the mental state to like do, whatever they've been charged with, because they were actually, in a mental health crisis. How does having, and you've answered this a little bit, but how does having it go through 988 rather than 911 change that like timeline from, because like when you like thinking about it in the criminal defense frame, like when you're bringing in the mental health issue, like in that frame, like primarily as a defense and very, very late. And so like how does the framing of 988 as like the first step to like a referral, like how does that change that?
I think with 988, the way that so let me start by saying 988, the only interaction we have with law enforcement as 988 is if we determine the person is at risk for death by suicide, meaning they have shared with us that they have a plan, they have a weapon, or they have a mechanism of some sort. It's going to happen. I'm going to do it in 30 minutes, or I'm going to do it right now. That is the only time we connect with law enforcement. That is part of our protocol. At that particular time, we transfer that call actually over to 911. Because now we need to identify who this person is. We need to find out their exact location. We don't have the ability to do that, only 911 does. And so we have to go and connect and transfer that person over to 911. Typically, we try to get the consent of the person on the line before we do that, but sometimes they don't give it to us. But we still do it anyway. We will still transfer that call over to 911 at that particular time. Going back to the coding, as far as what happens with the police coding, I think the reason why it's so important is that there are a lot of law enforcement entities and agencies now that are doing citations instead of arrests. And so you're issued a citation ticket where you just have to do a desk appearance. You might have to agree that you're going to go, you take that citation, and instead of it being you're taken to jail or you're taken to the emergency room, you either have to commit to going to services, going to a community-based service, and then the charge is dropped, or you commit to allowing the officer on site to call a crisis team out to you or take you to a crisis stabilization center, diversion center, or some sort. And so typically that is where, as long as the person agrees to do those things either on site or within the next 7 days, it varies across different entities how they handle it. Your charges are dropped, and so that's the end of where your connection into the service into the criminal justice system ends. You don't go down into the system where you actually need a public defender or an attorney to stand before the judge and kind of argue the case that, this was done because of mental health concerns. So that's kind of the reason why we want to ensure that we have access to how many times that happens. And if that is a practice that we need to implement and scale up, whether it's a citation instead of arrest kind of ticket, that's also why we need to have the codes so that we can reconcile those codes with the 911 data if we ever get to that point. It's going to take a lot of work to get the 911 data to where it needs to be, first of all. But if we ever get it to that point, then we can reconcile the data between 911 might report that we only get 30, I think right now they're like estimating it's like 24% of their calls that come into 911 call centers are related to behavioral health. Police are saying it's more like 65% of the calls that they respond to are behavioral health calls. And so there's a huge discrepancy there. So 911 is saying we send police out to 24, about 24% of behavioral health calls. Police are saying, yeah, but we're responding to about 65%. So you might send me on a burglary call, or you might send me on a trespassing call. But once I get there, after I've gotten the facts from the neighbors, from the people who are on the scene, we now have established that it's really a person having a psychotic break. And so it's not what the call that we received is. And so that's why we're saying that the coding is different. One, because of like issues like citation for not arrest, but also so that we can level out the discrepancy between 911 calls and then the actual calls that they're being dispatched out to. If that makes sense. I hope that makes sense.
No, that's fascinating.
We're almost at time, but Holly, you've got, they'll throw it quickly to you, just recognizing you've had your hand up for a minute.
Okay, yeah, you touched on this a little bit. I'm just curious about that actual intersection of mental health and criminal justice, in the sense of like, let's say someone calls 988, but like at what point, like when there is a crime committed, or at least alleged crime committed, like at what point is it still only the suicide intervention or whatever that you guys sort of cross over and engage with law enforcement and transfer that call to 911? Do you leave it up to the person who made the call or the person who alleged that the crime happened to like turn around and, you know, call police and say like, hey, this person robbed me or whatever. Does that make sense?
Yeah, the only policy we have in place where we transfer calls to 911 is suicide. That's it. That's the only one. If they advise us or share with us that there is a crime in progress of some sort, after hearing more about that from that particular person who was calling us, we may advise them to contact 911, but we are not going to contact 911 on that particular issue. Our only policy as it relates to connection to 911 is related to suicide only.
That has been wildly useful 90 minutes. Tiffany, thank you so much for being here. And while I recognize that this was not a training of trainers, but touching on your points earlier about spreading your communications message, I wanted to be known that we have a group here of able-bodied communicators who are able to continue to spread the great word of the work that your organization is doing, as well as the value of the 988 resource. So if we can support you, recognizing that we have these students across the country in helping to amplify your message, please don't hesitate to let me know.
That would be great, and I will definitely be doing that. And I'll also ask you, Jessalyn, if you can share my email with the group so that if they have any more questions that we didn't get to, and I'm like trying to go through the chat, like, did I miss something? Is there something over here? Please do not hesitate to reach out to me directly and ask me any questions that you have as it relates to SAMHSA 988. If it's anything about me personally and the work that I do or the work that I used to do, please reach out. If you have questions about the intersection of behavioral health and criminal justice, in general, I'm happy to either try to answer, or if I don't have the answer, I'll definitely try to connect you with my colleagues and friends and experts that I have in the field that might be able to provide you with more information.
Thank you so much for that. And as well as the professional development course that you charted at the very outset. I think just even that was fascinating, getting a better read on how you got to where you are in your career. So thank you for being here. Thank you for everyone who has stuck around, and enjoy the rest of your Monday. I'll look forward to seeing you back next Monday, when we'll be joined by Brandon Garrett at the Duke University School of Law, who'll be talking to us about police use of force policies. So thank you all. Enjoy the rest of your evening, and I'll talk to you soon.